Hello everyone and welcome to the second edition of Selected Topics in Pharmacology. I will discuss first pass effect today. The points to be covered in this session would be terminology, sites of the first pass effect, consequences, role of gut microbes, hepatic extraction, methods to obviate first pass effect and guide to further. First pass effect, pre-systemic metabolism and pre-systemic elimination have been used interchangeably, but the common term used is first pass effect that includes metabolism, elimination or activation also. Generally, the process of metabolism, that is inactivation of drug during its first passage from absorption site, that is GIT, to liver or other tissues before it reaches into systemic circulation is termed as pre-systemic elimination. The enterohepatic portal circulation and route of administration play an important role. It is the most common factor that reduces systemic bioavailability of many orally given drugs. First pass effect usually results in inactivation and reduced bioavailability, but may actually result in prodrug activation, contributing to the main action of the drug. First pass effect also results in making intermediates that undergo enterohepatic recycling and that contributes the temporary pool. The extent of the first pass effect varies from nature of the drug. The first pass effect determines route of administration and orally effective dose of a drug. For example, orally effective dose of propranolol is several times higher than parenteral dose, and the extent of the metabolism during first passage may occur in various tissues that include intestine, liver, lungs, and to a small extent some other tissues. It can be the first pass effect is saturable for some drugs that increasing dose will cause greater rise in the blood levels, as is seen with repeated doses of longer acting propranolol. First pass effect is altered by the diseases affecting liver and intestine. Gut microbes play a very important role. More than 1000 species of the intestinal microbes have been identified that remain in symbiotic relationship with the host. Their main role is to metabolize toxins, endogenous food-related toxins, and drugs during their passage in the lumen. So before absorption, first pass effect may occur. The gut microbes affect metabolism by influencing the activities of phase 1 and phase 2 enzymes, and intestinal drug transporters play a role in enterohepatic recycling of the drugs and can accumulate drugs within themselves also. So they play multiple role in mediation of first pass. And the relationship between drug and the gut microbes is bidirectional. Gut microbes change pharmacokinetics and pharmacodynamics of the drugs, and this is done by direct and indirect effects that we shall study. This will result in altered drug effect. However, drugs also alter first gut microbes that may result in altered drug effects as well as drug side effects. For example, Clostridium diarrhea with broad spectrum anti. Gut microbes have a characteristic metabolic effect, that is, unlike hepatic metabolism that results in water-soluble compound formation, the gut bacteria convert these water-soluble conjugates into lipophilic, sometimes active and more toxic compounds, as paracetamol I will discuss. Now this is done by metabolic process which are generally non-oxidative: reduction, hydrolysis, decarboxylation, dehydroxylation, dealkylation, and deamination, which remove or add some functional group on the drug, rendering it more lipophilic. Let's see the examples how the critical role of gut microbes in activation and inactivation of drugs like sulfasalazine, omeprazole, irinotecan, sodium picosulfate, diltiazem, and levodopa. Indirect effects of gut microbes on drug disposition are by altering the gene expression, protein levels, and activities of drug metabolism enzymes. And this is done by making certain chemicals by the gut microbes that bind to nuclear receptors that downregulate the expression of drug metabolizing enzyme genes. For example, for cytochrome 3A enzymes. Similarly, bacterially derived bile acids also affect nuclear receptors and gene expression of the cytochrome 3A isotypes. As a corollary, gut microbes may play a critical role in metformin's therapeutic efficacy in type 2 diabetes. Antibiotics increase the risk of drug toxicity. Example is paracetamol. Paracetamol normally undergoes conjugation and deconjugation by gut microbes, and then active product goes back into the liver for recycling. However, the gut microbes also produce paracresol from amino acid metabolism that competes with sulfation. So toxic formation is reduced actually, because paracetamol is more sulfated. But when we give antibiotics, they kill the microbes, and this killing will result in deconjugation. So more paracetamol would be available. Instead of getting conjugated, deconjugated, it will be more available. Simultaneously, gut microbes also do not produce paracresol because they are killed. So the sulfation reaction remains for paracetamol only, and there it becomes saturated. So paracetamol undergoes toxic formation, which is hepatotoxic. Pulmonary metabolism drug. Inhaled steroids, cyclosinide undergoes activation and inactivation. Inactivation is reversible and in the form of fatty acid conjugation in the lung. Fluticasone propionate is very little metabolized activated in lungs, whereas budesonide dipropionate undergoes hydrolysis in lungs to form active biclomethasone monopropionate and biclomethasone itself. Budesonide undergoes reversible fatty acid conjugation within the lung with oleic, linoleic or palmitic or arachidonic acid. These inactive metabolites can be reconverted back into active forms in the lung as and when needed, and this effect is currently known as soft drug effect. The motive behind this strategy is that body tissues are not exposed to higher level of toxic drugs or active compounds, and there is much more local effect as required. Momentazone furoate is metabolite into a minor epoxy metabolite in the beta-2 agonists to some extent, although a variable extent, for example, formoterol, salbutamol, and isoprene. They are inactivated through a process of demethylation or methylation or glucuronide formation. Now I'll give you two examples. One is gabapentin prodrug. Gabapentin prodrug and Carvel. It releases gabapentin by extensive first-pass hydrolysis in enterocytes. Now this prodrug avoids L-amino transport of gabapentin for absorption, and thus absorption becomes dose proportional and prolonged. Whereas if we give gabapentin without N-Carvel, it will not be dose proportional but saturable. This enhanced bioavailability necessitates reduction of its dose to about 1/3 of the immediate release gabapentin. The second example is a unique case of aspirin. Platelet inhibition by low doses of aspirin is related to its ability to inhibit COX-1 of the platelet which are present in the portal circulation at the time of its first passage from intestinal site. So it deacetylates platelets during first passage through liver, and it contributes to major antiplatelet action of the drug. Aspirin begins to acetylate platelets within minutes of reaching the pre-systemic circuit. Now, a measure of the hepatic ability to metabolize is hepatic extraction ratio, and it is calculated by hepatic drug clearance divided by hepatic blood flow, which is normally considered as 800 to 1500 ml per minute. The fraction of a dose that is absorbed and escapes first pass elimination, that is extraction, it measures the drug systemic bioavailability. That is, capital F is equal to fraction absorbed small f multiplied by 1 minus ER. For example, morphine is almost completely absorbed, so small f becomes 1, and hepatic clearance is 60 ml per hour per 7 kg. Therefore, extraction ratio is 0.67. Systemic bioavailability is 33%. The simplest calculation will tell that morphine systemic bioavailability is low. Propranolol is completely absorbed, but it is extensively cleared through liver, and its clearance approximates hepatic blood flow. Therefore, very little propranolol will reach in the active form in drug if smaller than 30 mg doses are given. But when oral dose is increased to 40 mg and above, this extraction ratio falls from 100% to 72%, and this increases availability of the drug. Generally, propranolol is available to the extent of bioavailable to the extent of 25%. Some important aspects of propranolol are the clearance almost exclusively from liver and is blood flow dependent clearance, not capacity dependent. Capacity is high. It is the blood flow that determines the total clearance. Propranolol reduces hepatic blood flow itself. Propranolol disposition depends on the stereoselectivity L versus DL propranolol. The clearance of the propranolol may vary with hepatic blood flow and liver disease, and also may change during the administration of other drugs which affect the hepatic metabolism, particularly hydroxylation reaction by cytochrome 2D6. What are the consequences of first pass effect? Several interpretations could be drawn. Pre-systemic elimination is a method of protection of host from dietary xenobiotic adverse effects. Pre-systemic elimination reduces bioavailability, and thus oral route may not be optimal for drugs like lidocaine, testosterone, isoprenaline, hydrocortisone, unmodified glyceryl trinitrate, and naloxone. Drugs that undergo moderately high first pass effect require higher oral dose. Propranolol, as only 25% reaches systemic circulation. Diclofenac, nifurtimox, ramelteon, salbutamol, verapamil, zaleplon, and other drugs also undergo extensive first pass effect. Therefore, their oral doses are high. In liver disease, drugs which undergo hepatic and gut wall elimination may heavily rely on gut wall metabolism in the form of first pass. In liver disease, bioavailability of some drugs may increase. Shared first pass metabolism may result in drug-drug interaction, particularly felodipine, cyclosporine. Drugs that undergo conjugation during first pass passage in liver and are secreted into bile would undergo deconjugation in the gut lumen by the intestinal microbes and thus get recirculated through enterohepatic cycling. Therefore, first pass effect contributes to temporary pooling of the drug in enterohepatic circulation. A wide inter-individual variation in the plasma levels to the extent of 20-fold has been shown by the drugs such as propranolol that undergo extensive pre-systemic. So now, what are the strategies to obviate first pass effect? Many changes have been suggested and done. Changes in the formulation, use of high-dose micronized progesterone in place of progesterone, NTRK-coated mesalamine, use of prodrugs using gabapentin and in place of gabapentin, using mestranol in place of ethinyl estradiol. Changing route. Transdermal estradiol is a classical example that shows fewer or no effect of the estrogen on hepatic protein synthesis, therefore effects on the clotting factors, lipoproteins, triglycerides are much lower, and therefore it reduces the risk of venous thromboembolism. Rectal, about 50% of the drug bypasses portal circulation and reaches directly into systemic circulation. However, if placed high, it will also reach into portal circulation. We use hydrocortisone ulcerative colitis for topical action this way. Parenteral route, intramuscular or IV can also be used, but for limited drugs. Sublingual route is also commonly used for some drugs, but again it is limited to fewer drugs. Using similar alternative compounds not undergoing first pass effect. The classical example is ethinyl estradiol in place of estradiol, pregabalin in place of pregabapentin. Now SDL for this session is mention two drugs that do not undergo first pass elimination, are not metabolized in liver, and are excreted unchanged mostly in urine. Explain why gabapentin is given as prodrug but pregabalin is not given, is a PG question. The third is ethinyl estradiol a prodrug for estradiol? A PG question. And fourth is, what is the significance of enterohepatic recycling of estrogens? So it is a guide to further reading, and you may find the session interesting, find the solutions to the SDL. You can also attend the next session on the learning pharmacology on the selected topics. Thank you and